Welcome to Vilnius, Lithuania.
Dear friends, dear colleagues, welcome back to the ESC Live studio. We are delighted to continue with another conversation on the topic that is shaping contemporary endodontics. It's a vital pulp therapy. This topic will be covered during the ESC autumn meeting in Vilnius this autumn. And today's interview will be led by my colleague, Dr. Inga Javorauskienė, who is also the member of the ESC Communication and Engagement Committee. And she will be joined by the Professor Tugba Turk, whose work has made an important contribution to the field of vital pulp therapy. So together, they will explore the latest evidence, current clinical perspectives, and some of the questions that continue to challenge us in everyday practice. Please join me in welcoming those ladies on the stage. And me and nice ESC ladies, Viviana and Monica, we will be working in the backstage, observing your comments and questions that we are going to overview after this interview. Ladies, the stage is yours.
Good afternoon, everyone. Can you hear me? So, good afternoon, everyone, and welcome to this European Society of Endodontology live interview session. And it's a real pleasure to be with you today from my beautiful hometown, Vilnius, Lithuania, where the upcoming ESC autumn meeting will take place. And I all invite you to join us in Vilnius and on this October. So, and at the ESC autumn meeting, one full day will be dedicated for pulp response, from scientific research to clinical practice. So today, I'm delighted to begin this online session with one of ESC autumn meeting speakers, Professor Tugba Turk. Yeah.
Hello.
So her topic will be about deep caries management, about exposed pulp and vital pulp treatment. And Tugba, your work speaks for itself, and you are deeply respected in the field of pulp biology and vital pulp treatment that you don't need here a long introduction. So thank you for joining us and welcome. And let's begin our conversation from the bigger picture. And the question is, where are we today? Okay, when we are talking about deep caries management, when we are talking about pulp exposure, when you're talking about vital pulp treatment. So the question is, how would you describe the current position of vital pulp treatment in modern endodontics? And is vital pulp treatment now an established evidence-based treatment, or we are still in the period of transition?
Okay, thank you, Inga. And first of all, I would like to thank you for this organization. And it's always a great honor to be all together with you. And also, we are beginning with a very nice question. Thank you for this question. Actually, I think we have passed the stage of asking whether vital pulp treatment works. And today, the evidence clearly supports VPT as a predictable treatment option in carefully selected cases. And the real challenge is no longer the treatment itself, but identifying which pulp have the potential to heal.
How would you describe the current position statement of vital pulp treatment when we are talking about deep caries management, when we are talking about vital pulp treatment, when we are talking about exposed pulp? And where are we today? And are they established evidence-based treatment? And are we still in the period of transition?
Yeah. Today, we are very sure about the predictability of these treatments. I would like to repeat again because I think it's very important. And we have passed the stage of asking whether vital pulp treatments works. Today, the evidence clearly supports pulp preservation techniques as a predictable treatment options in carefully selected cases.
Yeah, thank you.
Yeah.
And what has changed almost in this decade?
I think our understanding of pulp biology, we now know that even in inflamed pulp may retain the capacity to heal if the source of irritation is removed and the remaining tissue is healthy, and that has deeply changed our clinical approach.
Yeah, so but let's begin with the biggest clinical crossroads here. So the clinical decision when we have deep caries excavation. So should our primary goal still will be to not to expose the pulp, and where are the balance between the risk of to leave bacteria there and the risk of the pulp exposure?
Another critical question. I will say no, because I don't think our philosophy has changed. But our first goal should still be to preserve both dentin and pulp vitality whenever possible. The success of modern pulp preservation techniques should not encourage us to expose the pulp unnecessarily. If we can control the disease without pulp exposure, that remains the most biological and conservative approach. And VPT is an excellent treatment when exposure occurs, but it shouldn't become the reason for creating one.
Yeah, and when clinicians know when to stop the excavation, so what will be your advice for the clinicians, because many of them are watching us today, so when they should stop and say that I cleaned caries completely or not completely?
Okay, currently the evidence clearly supports selective caries removal in the carious lesions to reduce the risk of the pulp exposure while keeping the pulp vital. And this remains the key recommendations in the latest guidelines. The confidence in VPT should give us confidence to manage an exposure when it happens, not to create one unnecessarily.
Yeah, exactly. So excellent answer.
Yeah.
And the question for Milliam. So let's address the major paradox in modern endodontics, so pulp diagnosis. So I think that there is a gap here. Yeah. So, but how is in the clinical reality? Do we have enough pulp diagnostic methods? Can we guess if the pulp can heal or not? So, please explain us more about this maybe obstacle here.
Yeah, right. I think this is currently the biggest challenge in vital pulp treatments. And our treatments have advanced much faster than our diagnostic methods. We will still rely mainly on symptoms and sensibility tests, which doesn't always reflect the true biological status of the pulp. And histological studies have shown that pulp inflammation is often localized and highlighting the limitations of our current diagnostic approach. And the encouraging news is that a great deal of research is now focused on developing biologically based diagnostic methods, which I believe will shape the future of vital pulp treatments.
Yeah. So do you think, can we guess if the pulp can heal or not at these days with these diagnostic methods as we have today? What do you think?
Yeah, it's a very, very complex situation because the pulp inflammation is much more complex than patient symptoms. And pain indicates that inflammation is present, but it doesn't reliably reflect the pulp's healing potential. And histological studies have shown that inflammation may be limited to small area of the pulp tissue. So the teeth with the similar symptoms may have a different biological conditions. That's why symptoms alone cannot predict whether the pulp can heal. So we have to be on the balanced point with the clinical indications and the symptoms.
Okay, so my question is very, very clinical now. Okay, where does vital pulp treatment start, and where the Carious management finished when we expose pulp, and how we have to decide where to go for pulp cap, for vital pulp treatment? So explain us more, please.
Yeah, thank you. I think we don't have a strict border. Personally, I think VPT starts before the pulp is exposed. Once the caries reaches a deep dentin, the pulp is already responding, even if the patient has no symptoms. And histological studies have shown that these biological changes begin much earlier than we can detect clinically. So I believe every deep carious lesion should be managed with the aim of preserving the pulp. And for me, pulp exposure doesn't mark the beginning of the disease. It simply changes how we manage it.
Yeah, and sometimes when I place the filling, I can say I perform vital pulp treatment either. Yeah,
yeah,
because we're dealing with a pulp, we're exposed or not. So, what clinical findings influence your decision most? Which?
Yeah. I mean, at the clinic, I'm treating many. I'm doing many VPT, many pulp preservation treatments, but I never base my decision on a single finding. My approach is to look at the whole picture. I consider the patient's symptoms, sensibility test, the depth of the lesion, and if the pulp is exposed, the bleeding response. At the end, I'm trying to understand the biology behind those findings, because that's what guides my treatment decision.
Yeah, exactly. It's the same as we cannot bake the cake just from one end. We have to have a lot of ingredients. Yeah.
Yes.
So this is the same. We don't have just one.
Exactly.
Yeah. Thank you. So let's talk about the science a little bit and about S3 Guideline. Okay. And what S3 Guideline teaches us today. So because it's the most comprehensive evidence assessment in endodontics, we know that. Yeah. Our Bible, we can say that. And looking specifically at vital pulp treatment, what was the most important lesson we learned from analyzing all the available evidence from there?
Yeah. S3 guideline is the most comprehensive guideline for us, so it is very important and it's highlighting our clinical treatments, and it's very important. For me, the main message of S3 guideline is very clear. Vital pulp treatment is now an evidence-based treatment for carefully selected cases. But success doesn't depend only on the material. It depends on making right diagnosis, selecting the right case, and understand the biology of the pulp. As the only S3 level guideline in endodontics, it sends a very simple message: wherever possible, preserve the pulp tissue.
Yes, exactly. And I think that everybody should know this nowadays. And let's turn to clinical reality, and let's imagine in mature permanent teeth, we're excavating deep caries and we expose pulp, and the guideline said that they opened the gate for us to decide to go for the pulp cap, to go for the vital pulp treatment. As they say, do whatever you want. So how the clinician should decide what they have to do?
I think there is a good balance. The guideline got the balance right. Many clinicians, including myself, often lean towards pulpotomy in carious exposures because it removes the most inflamed superficial tissue. But the available evidence still is not strong enough to clearly recommend one procedure over the other. So for now, both are acceptable. The decision should be guided by the clinical situations.
Exactly. Okay, so what remains the greatest challenge in deep caries treatment and pulp exposure and vital pulp treatment? So maybe diagnosis, maybe case selection, maybe understanding the biology, or maybe us operators, or maybe education.
Actually, for me, it all comes back to diagnosis. If we cannot properly assess the biological status of the pulp tissue, even the best materials and the techniques won't give a predictable results. For diagnosis, yes, I think diagnosis is still the biggest challenge because we are trying to understand the biological process using indirect clinical tests. Also, case selection is important. Even an excellent treatment won't succeed if it's applied to wrong case. And the case selection is not just about the tooth, it is also about the patient. Their expectations, motivation, and commitment to follow up are all the part of decision. When we talk about the pulp biology, the more we understand the pulp biology, the better our clinical decisions become. That's why biology should guide our treatment, not just symptoms. And also, I need to talk about the operator technique. Technique is definitely matters. Using a good isolation methods, rubber dam, handling pulp gently, controlling the bleeding, achieving a good coronal seal are all critical. But these steps need to be combined with the right diagnosis and the right case selection. And at this point also, I need to talk about the education because it is essential because our philosophy has changed. It is no longer just about knowing how to perform pulp preservation techniques. It's about understanding why we preserve the pulp whenever possible. And because the science keeps evolving, we all need to keep learning and updating our practice.
Yes, exactly. And scientific evidence has evolved rapidly, and now it's clear that vital pulp treatment is widely acceptable treatment. But clinical practice and education often lag behind, and the question is why.
Yeah. I think these treatments has been discussed in endodontics for decades. So it's not surprising that the clinical practice take time to catch up with the evidence. Changing long-standing habits doesn't happen overnight, but I think we are moving in the right direction.
But maybe education changing too slowly.
It's improving.
Or maybe clinician is resistant to change.
I think the clinicians are more about being cautious than resistant. And in healthcare, that's actually a good thing. The challenge is finding the right balance between adapting a new evidence and maintaining the safe patient care.
Yeah, exactly. So the main message is that the pulp can heal, but we have to know how to create the environment.
Actually, exactly.
So we all are clinicians, and we all want that secret, what to do from tomorrow, what to do differently from tomorrow. So the clinical recommendation. So what would be your recommendation for the clinicians who are watching us today? So can you say your secrets?
Actually, they are not secrets. They are evidence-based clinical practice. And tomorrow is the clinical day before the summer holiday. So tomorrow morning, clinicians can confidently choose to preserve the pulp whenever it's biologically possible. We now have a strong evidence to support that approach. And at the same time, we should remain cautious about the diagnosis and case selection, because these still have the greatest influence on treatment outcomes.
But in your
Also,
sorry.
yeah, just I need to add sentences. We should stop assuming that every deep caries or traumatic pulp exposure requires pulp extirpation. And instead, we should first ask whether the pulp still has the capacity to heal.
And in your, you mentioned many times case selection. In your clinical practice, how do you do that? How did you choose the treatment?
I mean, actually, the clinical symptoms is important. As we talked before, the radiological examination is important, and also the patient's behavior is also important. Are they motivated to these kinds of treatments? I think it is important.
Okay, but usually you do 2D X-rays, or you're going for 3D X-rays, and what you are looking at the X-ray examination?
I mean, generally, I prefer 2D radiographs, periapical radiographs. I mean, if there is a very complex anatomy or if I see any strange anatomical properties, I go for 3D.
But in vital pulp treatment, do you think it's needed or no?
I mean, generally, it's not needed. Just a periapical radiographs are enough, according to me. Yeah.
Okay, good. And I got so many questions from the Instagram.
Oh, really?
Yeah. But
Okay.
I will not ask you directly. I will just ask you by some topics.
Yeah.
And some of them asked about when we have the pulp polyp, when we have a young patient and we have the polyp in the pulp. Is it indication to go for vital pulp treatment, or it's endo treatment?
Yeah, very nice question. Pulp polyps are generally, we observe these polyps in young patients. So it is a very good opportunity to do vital pulp treatment for these kinds of cases, because they are very well, they have a very well blood, so they are vital and they have a very strong blood infusion. So we may go for vital pulp therapies for pulp polyps.
Just full pulpotomy and the filling. Yeah.
I mean, actually, pulpotomy. Yeah.
Exactly.
Pulpotomy, I think, works better according to my clinical experience.
And one more question regarding periodontal ligament widening, because sometimes we know that we have periodontal ligament widening, and it's still no bacteria in the pulp, it is just inflammation. So what would be your advice if you do 2D X-ray and you see some PDL widening? Would you go for root canal treatment, or would you go for vital pulp treatment?
Here, also in many cases, the important thing is the health of the pulp tissue. Okay, you may observe a widening of the periodontal ligament, but it can be because of the radiological failure. So the most important thing to decide about the treatment modality is the pulp vitality. If it is vital and if you observe all the symptoms and they are all good for pulp vitality, so we may go for vital treatments.
Yeah, and of course it's very important, the vision. We have to see how the pulp looks like.
Yeah.
Many question was about obliteration, and calcification. When we perform vital pulp treatment, we got the calcification. So is it true or not?
Actually, in the past, the old dentists they all believe that we shouldn't do vital pulp therapy because we will face calcification. Actually, I mean, nowadays we have very good tested biomaterials. So with these biomaterials, this will heal like a guided endodontic treatment. So with the good treatment modality, if you clean all the inflammation, if you clean all the microorganisms very well, and if you use a good biomaterial, you will not face the calcification. Because there are very nice studies in the literature, they prove that if there is inflammation, if you leave there inflammation or microorganisms, you may face to calcification. So it is the reason for calcification. It's not because of the vital pulp therapy.
And some clinicians have fear of resorptions. So just few words about that.
Yeah. Also, the resorption, similar to the obliteration. Again, when you look at the literature, you may find very nice papers, and they just underline that it depends on the technique and the materials you use. Okay, if you clean very well the inflamed tissue, if you clean all the microorganisms, and if you use a hydraulic calcium silicate cement, a good biomaterials, normally you will not face with the resorption.
Yes, exactly.
If there is a resorption, also it can be related to the trauma before the patient has.
Yep, and the last question, okay? Because we are talking about what to do. So please advise the clinician, what should clinicians stop doing from tomorrow when they are performing this?
Okay, we should stop thinking all the endodontics means to pulp extirpation. Also, endodontics has a very good side of vital pulp therapies. I mean, I think endodontists knows pulp tissue very well. So our first aim should be keep the pulp tissue vital. Whenever it's possible, first we should go for pulp preservation techniques.
Yeah, so thank you, Tugba. It's always a pleasure to speak with you, and you are a great clinician, and your advices are perfect. And thank you for being with us today. And I wanted to invite all who are watching us today to Vilnius, in my hometown, where ESC Auto Meeting will take place at this year in October. So thank you, and see you all in Vilnius. Good night. Yeah.
Thank you so much. I also hope many of you will join us at the ESC Auto Meeting. It will be a unique opportunity to bring science and clinical practice together and exchange ideas and learn from each other. I look forward to meeting many of you there.
Yeah, ladies, it's not the end because we still have few questions. We were following all our social media channels, so we still have few questions. If you don't mind, Tugba, because some of them they are, I think, quite interesting. Tugba, what about artificial intelligence? Do you think it will change vital pulp therapy?
Yeah, very nice question. I think two popular topics meet in endodontics: artificial intelligence and pulp preservation techniques. Thank you for the question. My answer is yes, especially in diagnosis. I think artificial intelligence will. I don't think artificial intelligence will replace clinicians, but it can become an objective decision support tool. In one of our research studies, we found that artificial intelligence provides consistent, unbiased assessments, but the final decision, however, should always remain with the clinician.
Of course. Should not replace our brains, yes. Tugba, let's look at the future maybe and talk about a little bit about biomarkers. Probably we cannot apply them still, yes? This is only an experimental thing. But could eventually those biomarkers change how we select cases for the vital pulp?
It is.
And how far away we are from applying the biomarkers in our clinical practice?
It is a very important and promising area because we need a very good decision maker tools. And encouraging new is that a great deal of research is now focused on developing biologically based diagnostic methods, and which I believe will shape the future of vital pulp treatments. They are till now they are not clinically possible, but there are many in vitro studies. But I think in the near future we will have a very good diagnostic tools to understand the inflammation of the pulp tissue, the stage.
Yeah.
It's an important topic, yeah.
Nice question, probably just to close the discussion. Do you think vital pulp therapy will ultimately replace root canal treatment in the future?
Very nice question. I think very nice audience. Yeah, it is very important. I mean, we will more move to biological side by the time in the future, I think. But I mean, root canal treatment will always have an important role because it has a different indications. So both the treatments have different indications, because in vital pulp therapy, our goal is to simply preserve the pulp whenever it's biologically possible.
Thank you very much, ladies.
Thank you.
I think we have to say this is the end of this discussion. Of course, all the recordings you can see then on the Instagram, on the YouTube platform. It will always stay there. And on the Facebook. I think we can also place on the LinkedIn, because LinkedIn is not streaming this talk, unfortunately, not yet. Thank you very much, Tugba, and we will see you very soon in Vilnius. Warm welcome, and of course, warm welcome to everyone. Please join us, because it will be exciting meeting as always. A lot of discussions, one call, meeting face to face with our speakers, and having a good, great, and very important discussions, I think.
Yeah.
Thank you very much. Have a good evening. Have a good summer ahead. Have a good relax, and see you in the autumn meeting.
Thank you so much. See you in Vilnius.
Bye.
Have a nice summer. Bye.